Welcome to Making TRIPS Flexibilities Work, the civil society's role, challenges and successes, a webinar organized by Health Action International High and Public Citizen. My name is Judith Rius San Joan, and I will be your moderator today. This webinar is part of a broader work being developed by the Medical Innovations for All Consortium, a civil society consortium group funded by UNITAID and coordinated by WEMOS, with contributions from HI, KI, Knowledge Ecology International, Innovarte, and Medicines Law and Policy, aiming at addressing current obstacles to access to health technologies while supporting novel alternative approaches. Under the WTO TRIPS agreement, or the trade-related aspects of intellectual property rights, countries must grant patents, including for medicines. But the agreement also includes so-called flexibilities. There are different legal strategies that governments, and we will learn civil society, can use to prioritize public health and improve access to medicines. In 2001, so 25 years ago, all WTO member states agreed to the Doha Declaration on the TRIPS Agreement and Public Health that confirmed the right that countries have to use TRIPS flexibilities. As we will learn today, the term flexibilities includes a broad variety of legal and policy strategies, including compulsory license or use without authorization of the patent holder, parallel imports, strict patentability criteria or patent oppositions, bollard provisions, research exceptions, as well as limitations on remedies. Today, we will be listening from leaders in the field and experts from civil society on their experiences at national, regional, and international level involving the promotion of the use of TRIPS flexibilities to improve access to health technologies in different contexts and different geographies, from high-income countries to low, middle, and LDC countries. Presenters will share relevant practical experience in advocating and using TRIPS flexibilities, as well as research and resources they have produced to advocate for the useful use of TRIPS flexibilities. We have over 100 participant registers, currently over 50 participants in attendance. And we know many of you are experts in the field. So we strongly encourage you to use the chat function to share your resources, your experience, and your opinion, and to be with us during the question and answer session of this webinar. We have reserved 10 to 15 minutes at the end of the presentations for some discussions with all the audience. As Jaume mentioned, the recording of this webinar will be made available, and all the resources, including the bios of all the speakers, will be shared with you. So I'm going to be very unfair in the presentation of the different presenters and just announce them by name, title, and institution, because we have a very ambitious agenda. We have 6 presenters, followed by 4 responders. With your indulgence, we're proposing to extend the length of this webinar from 3 to 4:30, so 1 hour and a half, to allow for all the presenters and all the responders to share with us their expertise, but also to have a question and answer and discussion opportunity with all of you. So with further ado, I would like to introduce the first speaker, Monty Dunn, researcher at Medicines Law and Policy, who will be sharing the results of one of his research projects with, I believe, Helen Tejon and a group of institutional experts that we all know, on the use of several TRIPS flexibilities during 2001 to 2024. So what have we learned from over 24 years of experience in the use of several TRIPS flexibilities? Thank you, Monty. The floor is yours.
Thank you. Am I sharing the slides or?
You are sharing the slides, if that's okay, Monty.
Okay. Fine, I hope. Is that the correct window?
We are not seeing your slides yet. Now we see them. Yes, perfect.
Okay, fine, thank you. I'm very conscious that time is short, and so I am only going to speak about a very small part of the research paper. But as Judith mentioned, this is a paper looking at the use of TRIPS flexibilities from 2001 to 2084, so the last quarter century since the Doha Declaration. I think you should all have the link to the full article in the BMJ Global Health piece. The graphics I present are actually updated since then for the Lancet Commission in 2027. So, the first part of the data that I want to present is the instances of compulsory licensing across the last 25 years. And I've chosen to split this up into two time ranges for comparison. And further split the data up by World Bank classification of the countries in which the instances occur. So, comparing these two data groups, there's two main parts that I want to highlight to you. The first is the change in the distribution of World Bank classification. The vast majority of compulsory licenses instances in the first 10 or so years of their use since the Doha Declaration were made up of instances occurring in low-income and lower middle-income countries, and they were mostly for HIV medications. We've seen a real change over the last 15 years or so away from those countries. And in fact, over the last 12 years, there have been 0 instances of compulsory licensing in the lowest income countries. The next part of the data that I want to talk about is the execution status. So the TRIPS flexibilities database, which all of the data in the paper comes from, defines TRIPS flexibilities instances as where a government has made an announcement to invoke, actually invoked, or had a formal request to invoke a TRIPS flexibility. So here we've split up compulsory license instances as to those that actually were executed and those that were threatened but not executed. And then in the later age group, in recognition of the fact that compulsory licenses often take several years to occur, we also have pending instances. So aside from the change in the countries which make up the instances in our paper, you can also see a reduction in the execution rate of compulsory licensing. And there's a couple of theories as to what might be contributing to that. The main one that I want to point out in recognition of today's audience is the increased rate of civil society initiated compulsory licenses, which tend to have a lower execution rate, which I'll explore a bit further. So these two pie charts take different subsets of the data and split it up in the same way. The one on the left is all the compulsory license instances within our data set from 2001 to 2025, and split up again, executed, non-executed, and pending cases. And you can see that about 2/3 of all compulsory license instances in the data set were executed. And out of the third that were not, about 1/3 of those led to what we define as some kind of other access measure, and that is voluntary licensing or discounts or donations. And then there's also a few pending cases. If you look to the right, you'll compare this to the civil society initiated instances, and you'll see that there is a much lower execution rate, which at first sounds disheartening. If there have been, I can't do the maths, 31 or so instances, and only 3 of those have been executed, yeah, as I say, sounds disappointing. However, about half or just over did lead to some other kind of pro-access measure. And we explore in the discussion of the paper a bit further about what this means for the future of compulsory licenses initiated by civil society. I'm afraid I can't explore the data in much more detail than that, but thank you for listening. Please do read the paper and tell us any comments you have. Thanks.
Thank you, Monty, and all the co-authors. And just to reiterate, the full paper is available in the chat, and it will be made available for all the audience participating in this webinar. Next, I would like to ask Jaume Vidal from Health Action International to introduce his presentation. Thank you.
Thank you, Judith, and thank you everyone participating in this webinar. I'm going to share my screen, and I hope it works. Well, I hope that you are seeing what I'm seeing.
We can see, not on presentation mode, but we can see the slides. You might want to switch it to presentation mode.
Okay. It's good now? We're still active.
Still not on presentation mode, but we can see them.
Okay, yeah. I think that it will have to be like this. So I'm going to be very brief. I'm going to be touching on two topics, and I will try not to go too fast for like our interpreter. I'm going to be talking about the treat flexibilities navigator and the context in the European Union of the use of these flexibilities. First, I think that it's important to mention that this tool, the Treat Flexibilities Navigator, originated in a collective effort in a workshop that I held in 2020 with some of the participants in this webinar precisely. And the idea was to gather information that was separated or isolated in different sources and put it in the same place. The idea was to reinforce the evidence-based advocacy work of HI with this, we can call it like hard data. And here you can see like the kind of information that you can find in this navigator. Lucy, if you can put all the links regarding the flexibilities navigator and HI's work on the topic, because the issue here it's really it's an integral part of this strategy in the sense that what we are looking at it's like why we can use flexibilities, how we can use them, and what are the main factors. I think that it combines very well with what Monty was referring, mainly because we use the medicines law and policy database on the use of these flexibilities as well as other, as the European Patent Office and the medicines patent pool. And you can see that in 6 years, like the Digital Flexibilities Navigator has grown in scope and has grown in reach. We have like now hundreds of unique visitors per month, and we are able to provide information on a wide range of products. We have also expanded the countries that we cover. It's not only Europe, but also the Americas.
Apologies to interrupt. The slides are not advancing, so we're still in the first page. I hope that's okay.
Yeah, that's okay. That's okay.
Okay, apologies.
Yeah. No worries. No worries. It's only 2 slides, but I spent a lot of time in each slide. So the issue here it's really like that it has grown and it has always grown with the participation of the community, of the users, and also supporters. And I think that Lucy is putting like the links to the both the flexibilities navigator, but also the user guides and other knowledge products on the flexibilities. And for us, it's very important to really like, and I think that the BMJ article that Monty and others produced, it's important because it's really, you can see that this flexibilities is becoming something common in different circumscriptions. And when coming to Europe, it's something that we need to really bear in mind that we live in TIPS plus territory. I mean, the sense that it's really, you have like some instruments and some features in the legal and regulatory framework that makes it more complex to make use of flexibilities. I'm not saying that it's impossible, but it's more difficult. And something that we have noticed at Health Action International is that you see there is like the public sentiment or like the public debate or discussions that is becoming more sensitized about like the importance of flexibilities, like the dangers of like a maximalist approach to IP. But then, and I think that Ella's presentation is going to be very clear on this aspect, it's difficult to translate this public sentiment into legal and policy changes, especially lasting changes. And I will mention like some very briefly some recent discussions that we have had at EU level with the reform of supplementary protection certificates or the compulsory licensing for emergency settings, both processes with a lot of potential that at the end it was sort of discouraging to see that a very pro-industry approach was the one that really shaped the final result. And something very interesting, I think, happened with the trade negotiations with Mercosur, something like a process that we followed for like a lot for over a decade in collaboration with Latin American organizations, and we were very satisfied in the sense that trade flexibilities, the policy space for trade flexibilities had been like maintained even in the final text agreed. And I'm sure that you have read in the last month, the Argentinian government has decided to change the patentability rules. And I can see Judith, and I know what she wants. So, and I think in terms of the European Commission, what we see is a formal qualified support for the flexibilities, that it's only nominal and it's not kind of say effective when it comes to high-level meetings at the UN General Assembly or negotiations of the pandemic accord. Thank you, and excuse me if I went over time.
Thank you, Jaume. And I know this is going to be impossible effort for everybody. We are asked, the organizers have asked all the speakers and the respondents to have just 5 minutes to allow for times for discussion. So thank you, Jaume. I'm going to ask Ella Weven from WEMOS, a coordinator of the MIFA consortium, to present her thoughts next. Thank you, Ella.
Yes, hello, good afternoon everyone. My name is Ella Weggen and I work for WEMOS. WEMOS is a global health foundation based in the Netherlands. I'm the team lead of the Access to Medicines team. And I'm also the coordinator of the consortium called Medical Innovations for All on the use of trade flexibilities, and we are funded by Unitate. KI, Health Action International, Innovarte, WEMOS are part of this consortium, and also as subcontractors Medicines Law and Policy, Universities Allied for Essential Medicines, and Alfiana Haki. We do advocacy in high-income countries and on a global level, and we work on the use of trade flexibilities, voluntary licensing, social responsible licensing, conditioning of public funding, pandemic preparedness, transparency of pharmaceutical markets, regional production. I'm going to talk a little bit about the developments in the Netherlands today. In 2019, Minister Wiebes from Economic Affairs, he appointed a compulsory licensing committee in the Netherlands to advise on when to use such a license. This followed the 2017 recommendations by the Council for Public Health and Society, Raad voor de Volksgezondheid en Samenleving, to start using CLs. Also, the Netherlands Court of Audit, the Algemene Rekenkamer, indicated that the Minister of Health should say no more often during negotiations with companies. By using a CL, the Minister of Health and Economic Affairs can go one step further. They make the medicine accessible to patients at a reasonable price by granting another manufacturer the right to produce the medicine and bring it to market at a reasonable price. There were balanced arguments during the investigation. There might be downsides to the use of CLs. In the first place, the IP rights of a pharmaceutical company are restricted by the government. That is in itself a drastic step with potential negative repercussions for the Dutch innovation climate and business climate. Furthermore, producing medicines is generally no easy task due to the strict quality requirements. But this investigation, this committee that was set up to investigate this, completely turned out in the wrong way, because one of the committee members appeared to be using arguments sourced directly from pharmaceutical industry lobbyists, sworn opponents of the use of compulsory licensing, to reject the final report. Consequently, committee chairman André de Jong, he had to send the minister a personal reflection instead of a report. This was really a pity. This one committee member, Harold van Barlingen, works for a venture capital fund, and it fell apart when he attached a Word document to an email to the rest of the committee members with track changes that revealed that it came directly from the pharmaceutical interest group Holland Bio. 3 other committee members, amongst others Ellen Hoen, withdrew their confidence in this one member, who was subsequently asked by the chairman to step down. And this was something he refused. Then the chairman had no other option but to write an analysis on his own account. There were still very interesting points in this analysis. The rationale behind the use of compulsory licensing, the threat thereof in this context is that it provides the government with a legal instrument to lower the high prices charged by pharmaceutical companies for new patented medicines, thereby making them more available. In his personal reflections, Committee Chairman de Jong makes a number of strong recommendations. When an overpriced medicine whose patent is far from expiring, which significantly improves patients' health, can be replicated, and when the use of CL is not expected to have major negative effects on the innovation climate and the availability of other innovative medicines in the Netherlands, then action must match words, he said. In other words, do not merely threaten with compulsory licenses, but actually use them in extreme cases so that pharmaceutical companies know that governments are prepared to actually use that instrument of power if they keep medicine prices exorbitantly high. Dutch legislation does not need to be amended for this, but it still needs to be arranged at European level that pharmaceutical companies have an obligation to make their data available and to relinquish their market exclusivity. According to de Jong, a compulsory license can also have a positive consequence for future negotiations due to its deterrent effect. An additional point is that the government often makes a significant contribution to the development of a new medicine in early stages through the funding of fundamental and clinical research, thereby reinforcing the impression that the citizen as a taxpayer has to pay twice for the medicines. So this is what happened in the committee. Unfortunately, after this happened over 6 years ago, the topic of compulsory license never got back on the agenda in the Netherlands. And at this moment, it seems unlikely to happen in the current political landscape. So we are, of course, as WEMOS, very much interested in what we can do to have this topic again on the agenda. And I'm looking forward to hearing more today, also of other countries, how we can make this happen. This is where I would like to leave it. Thank you very much. And yes, I'm looking forward to the questions later.
Thank you, Ellen. Very, very important, very interesting. I would like to invite our next presenter, Jamie Love, Director of Knowledge Ecology International, KEI, to share his presentation with us. I don't know, Jamie, if you would like to share your slides, if you're ready.
I would. Let me see if I can get this to work here.
Thank you.
Thank you. See if I can get this to work here. I wanted to talk about are you able to see the slides like this? Okay.
Yeah, very clear, Jimmy.
Well, I want to talk about a way to do non-voluntary authorizations, which is often ignored by groups, even though it's numerically the most common way that compulsory licensing has been done. And what a lot of people focus on is what they call part 2 of the TRIPS. Part 1 of the TRIPS agreement of the WTO is sort of sets out some general provisions. Part 2 breaks it down for like particular types of IP. So you have something different for copyright than you have for patents or other types of intellectual property. And in there's particular provisions that deal with compulsory licensing or other types of non-voluntary authorizations, and people often focus just on that. However, on part 3 of the TRIPS, which has to do with the enforcement of rights, is probably, I think, the most important flexibility, and that is the section on injunctions, and that's what I'm going to talk about. Now, Article 44 of the TRIPS is the section on injunctions. And why is this important? Well, if you have a patent or a copyright or a right in data or any other intellectual property right that was addressed in the TRIPS agreement, you can have a right, but whether that right, how you exercise that right depends on the enforcement. And you're allowed to withhold injunctions either by court in a discretionary, which would be this paragraph 1 of Article 44, or you can just by statute just take injunctions completely off the table. And both of these things have been done by different countries. You see it for copyright in some countries, but in the United States, they do it most importantly in the area of patents. And I'm going to skip over this because I know that there's a lot of speakers today, but I'm going to go to the second paragraph in Article 44 of the TRIPS. And it says, like basically the first part says that the judge has a discretion whether to grant a compulsory license, an injunction or not. And let me go back to Article 1. So why is this important? Well, in medical device cases in the United States, it's often the case, or it's happened quite a few times, that a patent owner has tried to enforce an injunction on a patent for a medical device, and a court has not granted the injunction, and they've allowed the infringing party to continue to manufacture the medical device and sell it subject to a running royalty. So in that case, the judges themselves effectively issue a compulsory license. And they've done this not only for patents, they've also done this for trade secrets for medical devices. Now, even better, in the second paragraph in Article 44, there's two sentences. And the first one says that you can, if there's some sort of government use, you don't have to offer an injunction. That's fine. But the best part is the second sentence. And that says that you can completely take injunctions off the table, and you can allow people to use a patent without permission of the patent owner. And I've cited on the column on the right all these different cases in U.S. law where this is actually done. And also, I've cited some cases in other, other laws, particularly in the copyright area, toward the other end. Now, this is what the U.S. statute looks like. It says whenever an invention is described in and covered by a patent in the United States without the right to use it, your remedies are limited to money, getting compensation. And the way this is implemented in practice is there's something called the Federal Acquisition Regulations. And it covers all federal agencies. And basically, it looks like this. There's these clauses in the federal I'm going to go to 2271. They have these clauses that you can go authorization and consent. So if you make a reference in a contract to this authorization and consent, that's all you have to do in a contract, and I'll show you how that's been done. In contracts. First of all, there's no requirement that you have to negotiate there's no requirement that you have to negotiate with the patent owners in using this. Trying to figure out why I don't have the screen going the right way here. There are no restrictions on imports or exports. There's no balancing test or grounds required. There's no waiting period. The federal government has a clear right to use this authorization whenever it wants to, and the patent owner is entitled to compensation, but only from the federal government. Now, I'm going to just show you several examples of where this is actually done. These are contracts that we have that includes this clause. And in this current case, well, we have in this particular thing, this is just from BARDA. This is from one federal agency. And there's 83 contracts in this particular tab. And then we have contracts at HHH, the CDC, Department of Health and Human Services. Oh no, this is Homeland Security. These are Department of Defense ones. Department of Defense ones, we have 100 contracts. We have 35 contracts from DOE. I must say, we could have had a lot more contracts in here. We just got tired of adding them after a while because it's used so commonly. And I just want to show you. You're seeing this, right? This is good. Okay.
We're seeing Jamie. Just the
you
time
want
is coming
me
to an
to
end.
wind up, right? Because I've talked for 6.5 minutes, right? So, I want to show you just an example of the last thing I'll show you is how this is done in an actual contract. So this is I'm going to go to page 87 of this contract. This is a contract that's disclosed by this company. They have a contract to develop vaccines. And if I go to page, it'll take me a second here. Now, the way this works is that there's a statute and then there's a regulation in place which spells out the authorization, the right to use patents, any patent granted by the U.S. government without negotiation, any patent that's granted now, any patent that's granted in the future. I mean, it's the broadest possible. No restrictions on imports, no restrictions on exports. And here, right here, in this one sentence here, it says 522.227-1, authorization and consent, alternative 1, April 1984, period. Now, if that clause is in your contract, it's one of the things that you're allowed to do, and it's under this section called contract clauses. Then you have a compulsory license, and that's all the U.S. government has to do an authorization, and they do it a lot. And one of the frustrations we have is when people talk about compulsory license, they just sort of skip over what the United States has been doing for years, and they do a lot, and they did over 50 times during COVID-19. And I wanted to bring this to your attention because we're trying to get people not only to understand what the U.S. is doing, but to look at this in terms of best practice for new legislation in countries, including countries that are graduating from the LDC status, like Cambodia and Laos. And they should consider implementing a system closer to what the U.S. does than what a lot of other countries do. Thank you very much.
Thank you, Jamie. Very important as always. Apologies for interrupting all the speakers, trying to keep the agenda moving. I would like to invite Luis Villarroel now, a director from Innovarte Chile, to present his experience and his work in Latin America. Thank you, and in the world.
Thank you very much, Judith. I'm the director of Innovarte. It's an NGO based in Chile, but we work in Latin America and also in Geneva with our colleagues from the MIFA consortium that Ella has presented already. And our background is in compulsory licensing. We have requested 2 in Chile, and also we have supported in Peru other compulsory license requests. So from that experience, I will speak, and also we have been researching the availability of TRIPS flexibilities in Latin America. I'd like to upload my presentation, and I hope it's there. Okay, so we have been researching, and I would say a little bit obsessed on the possibility of the use of what James was mentioning, that is the Article 44.2, the possibility of limiting the injunctions, permanent injunctions that is permitted by TRIPS, and it has two possibilities. One, you can see it, as James mentioned, as a form of government use, but also it can be used as a possibility that the judges do not grant a permanent injunction like in the US, the eBay case, but also because of equity. This possibility of this flexibility, which we think that is one of the most flexible and with with a fast implementation is not present in any Latin American country that we have studied. So that creates a very important gap. Also, despite that there is the possibility of government use now under Article 31, almost no country in Latin America except Ecuador, they have differentiated government use from compulsory licensing. So what happened is that even if you are doing a government use, you need to go through the very lengthy process of compulsory licensing according to Latin American countries' law. Also, we see that there is underuse of the possibility of exceptions. Still, there are a number of exceptions that are not available in all countries, like, for example, preparation of medicines. But in general, there are enough grounds for compulsory licensing. And the question is, why don't we have more compulsory licensing? And the answer is based on, I think, two areas. One is that despite there is the possibility of the compulsory licensing, we have a restriction on court interpretation. The best example is the Andean case for etoricoxib, where the requirements for a compulsory licensing in the case of a pandemic was extremely complex and not feasible. Also, if you see in the case of Chile, to go through a compulsory licensing process, which is do not differentiate the government use from regular compulsory licensing, it can take 3 to 4 years. And so when we go to change these laws and we try to implement the compulsory licensing, we face some important challenges. First, and I think it has been mentioned, like in the case of the Dutch, is that there is an honest belief in many stakeholders, and that the TRIPS flexibility will undermine the possibility of getting investment in innovation. So you have a problem there because we need to explain how it works the other way. The other is the very complex is the fear of retaliation from drug companies, and also that even patients that are not willing to accept the idea of a compulsory licensing and get a generic, like has been the case in Peru with Trikafta, where the patients, the fibrosis cystica, they have dissociated from the request. And in short, on the political level, intellectual property is not seen as a priority. And I think I'm with 5 minutes, and I will stop with this final slide that what has worked to us when we succeed with the compulsory licensing for sosufovir was to engage political leaders, to get a leader, in the political side to push for it, to get a leader from patients, and to make an economic case, not only humanitarian. And finally, very, very important, the support of civil society to sort out the other challenges. And I stop here. Thank you.
Thank you, Luis. Very important work. I really like this last slide. Now we're moving to the last of our presenters, Luz Marina Umbazia, who is the coordinator for PIMAC-LAC Medicinas para la Gente, capítulo Latinoamericano, and director of Global Humanitarian Progress Coordinator. She's based in Bogota. I believe Luz Marina is going to be speaking in Spanish. Correct me if I'm wrong, Luz Marina. And if that's the case, I remind everybody that we have live translation from Spanish to English. So you can just switch to English if the presentation is done in Spanish, and the recording is going to be made available if you want to listen to it and practice your Spanish in a slower pace. Luz Marina, the floor is yours. Puedes empezar, Luz Marina. Gracias.
Thank you, Judith. Good morning And good afternoon, everyone. Thank you for the invitation and the opportunity to be part of the discussion. How Judith said, I will speak in Spanish, but the slides are in English. Can I share my screen?
Sí, Luis, por favor, ¿puedes dejar de compartir tus slides y así Luz Marina puede compartir las suyas?
I don't have control for this.
You do not?
No.
Okay.
Okay, there you are. Okay, sorry.
No worries, Luz Marina.
Okay, thank you. Bueno, el día de hoy voy a hablarles sobre las redes y la cooperación entre las organizaciones de la sociedad civil en Latinoamérica. Estos logos que ustedes ven acá son algunas de las organizaciones y redes que actualmente nos están acompañando en esta alianza por el acceso a medicamentos y el uso de las flexibilidades TRIP. No sé por qué, no sé si estoy compartiendo mi pantalla.
Estamos viendo tus slides muy claramente.
Pero no son los míos, o sea, no soy yo quien está
No, es
compartiendo.
Yo creo que tienes que decir
perfecto.
siguiente y
Okay,
ellos van cambiando.
Okay.
Sí.
Ok, bueno, este trabajo en redes en Latinoamérica empezó aproximadamente desde 2008 hasta la fecha. Hemos tenido buenos y malos tiempos, pero siempre hemos estado enfocados en la implementación de flexibilidades. Como todos sabemos, las flexibilidades están en la norma, pero para que se hagan efectivas es necesario que haya una capacidad técnica, una voluntad política, un apoyo jurídico y, por supuesto, el respaldo de las organizaciones de sociedad civil y de las organizaciones de pacientes. Con el paso de los años hemos logrado generar una infraestructura interna que nos permite coordinar digamos que entre países transfronterizamente nuestros argumentos, las actividades, porque cada uno de los países tiene una idiosincrasia y hemos logrado construir una estructura que nos permite manejarnos como región. Hemos hecho alianzas con organismos de cooperación como la OPS, la Organización Mundial de la Salud, ONU-SIDA, Medicine Patent Pools y otras ONGs y redes globales como ITPC, como Oxfam. Y en nuestras actividades hemos alcanzado a abordar y a obtener el respaldo de más de 100 organizaciones de la sociedad civil y líderes también. Nuestros alcances en Latinoamérica respecto a los TRIPS se han traducido en solicitudes de licencia obligatoria desde el inicio en Caletra, después estuvimos haciendo solicitudes para Tazanavir en el Perú, estuvimos empujando la conformación de la norma que permitió en Ecuador desarrollar y que se obtuvieran estas licencias obligatorias por una vía administrativa. Hemos pasado por los antivirales de acción directa de hepatitis durante la pandemia y actualmente finalmente hemos logrado una licencia obligatoria en Colombia para dolutegravir y para sofosbuvir, esta última que desde hace varios años, desde 2015, se había hecho una solicitud inicial. Actualmente nos encontramos en la campaña de acceso al Lenacapavir, enfocados en los temas de precio, en los temas de registro, porque como ustedes saben, Latinoamérica, la mayoría de los países, solo 2 o 3 de ellos están incluidos en la licencia voluntaria de Gilead. La mayoría de nuestros países están calificados como países de ingreso medio alto, por lo tanto no tenemos acceso a licencias voluntarias. Pero tenemos un gran problema de inequidad. Por lo tanto, sí son necesarias el uso de este mecanismo porque no todos podrán acceder a las nuevas tecnologías. Hemos tenido también solicitudes de licencia obligatoria para medicamentos como Trikafta, que es un medicamento para la fibrosis quística. Siguiente. Siguiente diapositiva, porfa. Gracias. Nuestros resultados, tenemos evidencia empírica en el impacto frente a las flexibilidades de ADPIC. Tenemos disminución en los costos cuando no hemos obtenido licencias obligatorias, disminuciones en los costos de los medicamentos que han ido desde el 40% al 90% en el costo del precio. Finalmente, el año antepasado obtuvimos la licencia obligatoria de dolutegravir y de sofosbuvir, que está en este momento en proceso la convocatoria de los licenciatarios. Esto ha hecho que todo este trabajo que se ha hecho durante tantos años ha permitido que las flexibilidades tengan una legitimidad frente a los gobiernos, que los gobiernos las hayan conocido. Se han desarrollado normas para reglamentar el ADPIC, porque cuando empezamos a trabajar en esto, los países no tenían reglamentación frente a estos temas. Hemos tenido impacto económico, hemos desarrollado otras actividades que se han fortalecido a la par, como es el seguimiento y el monitoreo de los precios de medicamentos, la identificación de nuevas metodologías que nos permiten presentar informes y desarrollar estudios que son evidencia para la toma de decisiones fiscales de los gobiernos. Y actualmente pues estamos haciendo procesos de monitoreo de precios de medicamentos y de patentes. En cuanto a los impactos de las organizaciones y la cooperación sur-sur, obviamente que el entrenamiento y la formación que se le ha dado a los actores de la sociedad civil ha sido, digamos que una de las fortalezas, porque quienes están exigiendo su derecho en cada país a una licencia obligatoria tienen un conocimiento del tema. El riesgo político, como todos saben, este tema genera tensiones políticas. Cuando se hace en conjunto, ese riesgo se ve disminuido porque es una voz regional de la sociedad civil, y esto también nos ha ayudado bastante. Hemos tenido la oportunidad de participar en reuniones de negociación de tratados de libre comercio, como el Acuerdo de Asociación Transpacífico. Hemos dirigido muchos comunicados, más de 15 comunicados a los gobiernos y a las industria farmacéutica, exigiendo el derecho al acceso a los medicamentos. Y frente a acciones legales y de advocacy hemos tenido seguimiento y apoyo a acciones judiciales que las farmacéuticas han iniciado en contra de los estados. En conclusión, las redes han ayudado a transformar la política pública regional, han sido importantes también para generar impacto económico en los precios de los medicamentos, y definitivamente el fortalecimiento de las alianzas permiten el acceso a medicamentos en la región. Como desafíos tenemos que cada vez es más complejo cómo se desarrollan los mercados. La industria farmacéutica es camaleónica, por lo tanto no es tan sencillo establecer estrategias para poder tomar ventaja y acceder a los medicamentos. La judicialización a la que siempre acude la industria, la falta de sostenibilidad financiera para las redes y las agendas regulatorias emergentes. Gracias.
Gracias, Luz Marina. Thank you, Luz Marina. So this is the end of our speakers list. Now we're going to move to our responders. We have 4 responders. I'm going to ask first Juliana López, Director of IFARMA, and Manuel Machado, Scientific Researcher at Misión Salud, both from Colombia, to share their experience as working as civil society organizations in Colombia working on the issue. Juliana and Manuel, the floor is yours. I believe you're going to be sharing the floor. Thank you.
Hola, muy buenos días. Acá nos encontramos Manuel Machado de Misión Salud y quien les hablará posteriormente.
Thank you so much. I think that Manuel is first. We are speaking Spanish too, so please keep your translation on.
Perfecto. Entonces, si les parece, voy a compartir pantalla.
Gracias, estamos listos. Por favor, compartan su pantalla.
Bien. Entonces, por favor, creo que ya la podemos ver.
Ahora podemos ver. Gracias.
Listo. Muchísimas gracias. Entonces, permítanme un momento mientras que proyecta. Perfecto. Entonces, ya como bien lo dijeron, estamos Manuel Machado de Misión Salud y Juliana López de Pharma. Entonces, la idea es mostrarles las experiencias en Colombia sobre el uso de las flexibilidades en propiedad intelectual. Entonces, la idea es mostrarles unos intentos previos. El primero de ellos se dio durante el año 2008, en el cual un grupo de organizaciones de sociedad civil, entre las cuales estuvieron Misión Salud y Farma y otras, se presentó la solicitud de una licencia obligatoria para los fármacos del Lopinavir y Tonavir que en su momento se usaron para el VIH, para un medicamento de marca de cierto laboratorio. Desafortunadamente, para este caso, la licencia no fue obtenida. Sin embargo, se logró obtener una reducción del precio de alrededor del 90%, lo cual pues fue una victoria parcial en términos de acceso, ya que pues una reducción del precio se traduce en una facilidad de acceso, en especial por las dificultades de los sistemas de salud y de los recursos. En segundo lugar, se obtuvo otro intento de licencia obligatoria, ¿sí? En el cual fue para otro fármaco que fue el imatinib. Este fue en el 2016, en el cual nuevamente se hizo la solicitud de licencia obligatoria, hubo una declaratoria de interés público. Sin embargo, por presiones de distintos actores, pues desafortunadamente no fue posible. No obstante, también se logró una reducción del precio del 44%. Afortunadamente, y ya otros expositores lo han hablado en los momentos previos, en 2023 se logró la declaratoria de interés público para el fármaco dolutegravir, el cual, como ya se ha indicado, es el fármaco de primera línea para el VIH. Y pues como podemos ver en la imagen, fueron varias organizaciones de sociedad civil y otras instancias interesadas, entre las cuales también estuvieron Misión Salud y Farma, el Comité de Veeduría y Cooperación en Salud, las cuales presentamos aportes y evidencia para favorecer dicha declaratoria. Ya posteriormente Juliana entrará en detalle de cómo se dio esta licencia y le doy la palabra a ella para que le dé continuidad.
Muchísimas gracias, Manuel. Buenos días y buenas tardes para todos y todas. Si quieres, puedes avanzar en la siguiente diapositiva, Manuel. Gracias. Bueno, yo voy a hablar específicamente del uso de las flexibilidades de látex acá en Colombia. No voy a entrar pues como en mucho detalle, ya que tanto Luz Marina como Manuel pues han de pronto explicado esto con un poco más de profundidad. Eh, bueno, dando como continuidad a lo que dijo Manuel, recientemente nosotros obtuvimos la primera licencia obligatoria para un medicamento acá en Colombia, que pues fue para el dolutegravir. Recordemos que las licencias obligatorias permiten producir o importar medicamentos genéricos sin el permiso del titular de la patente, pues todo en favor del interés público. Que ha sido un proceso pues largo, digamos, un poco desde el punto de vista de la sociedad civil. Ha sido largo desde el 2024, que fue la declaratoria de interés público, hasta la expedición como tal de la licencia obligatoria, pues ha pasado siempre bastante tiempo. Ya nos encontramos en la fase de implementación, la cual también pues ha tenido algunos baches, algunos problemas para su implementación, pero pues que responden más a otras lógicas dentro de la misma política del país, pero pues digamos que desde Fundación IFARMA, que somos una organización de la sociedad civil, venimos haciendo un seguimiento pues como muy juicioso a esta implementación. Cabe destacar que retomando un poco lo que dijo Luz Marina, un desafío muy importante ha sido la judicialización del uso de esta licencia, la cual ya lleva un poco 4 y contando demandas en contra tanto de la declaratoria de interés público como de la expedición de la licencia obligatoria, en la cual pues IFARMA ha participado como coadyuvante en varias de estas demandas. Esto con lo que tiene que ver con las licencias, con las licencias obligatorias. Es importante resaltar acá que ya hace un par de semanas nuevamente se hizo declaratoria de interés público para antivirales de acción directa, algo que ya se había hecho hace un par de años, pero pues en su momento solo se logró como que entraran en el mecanismo de compra centralizada. Ahorita nuevamente se pide declaratoria de interés público y bueno, pues tenemos como la esperanza de que podamos también tener una licencia obligatoria para este medicamento.
Juliana, me disculpo, estamos sin mucho tiempo. Tenemos que dar paso a los siguientes. Si quieres concluir.
Okay. No, bueno, voy a concluir como con algunas de las acciones que podemos hacer desde la sociedad civil. La primera, pues, mantenernos informados y exigir que las decisiones de la salud siempre prioricen la vida y no las ganancias. Participar en las organizaciones comunitarias que vigilan precios, acceso y calidad de las patentes y pues acompañar los procesos de defensa del derecho a la salud y sobre todo pues promover el uso de las salvaguardas de la salud pública. Entonces, con eso podría cerrar en este momento. Gracias.
Muchísimas gracias, Juliana. Y Manuel, I'm now giving the floor to Gopa, legal advisor at Third World Network, that is going to be giving his perspectives and the perspective of Third World Network concerning their work on patent oppositions in India, making the voice of patients count. Gopa, the floor is yours.
Thank you. I request to share my slides. So thanks. While my colleagues will be sharing the slides, so let me just start by saying that the civil society organizations in India played a major role in shaping India's patent law. Next slide, please. This role, in fact, started even during the negotiation of the TRIPS agreement in late 1980s onwards, and continued to work on safeguarding public interest provisions in the India's Patent Act. The post-amendment, civil society's role was mainly in two ways. The first one is to keep on monitoring any attempt by any actors to dilute the public interest safeguards in the Patent Act. And second one is the kind of more of using some of these flexibilities. I'll be focusing on the second part. And the direct efforts are always, we know that, to dilute the public interest safeguards or public health safeguards by through the FTA negotiations or bilateral investment treaties, and indirect efforts mainly by the patent officers to not to apply some of the strict patentability criteria. So in India, though we do have a very strong provision, but patent office ended up granting many patents for non-molecules. So we have started an initiative to ensure the accountability of the patent office. Eventually, we feel that that will be much more of a civil society movement to keep a watch on the patent office. A patent office watch kind of action will be developing in the coming days. Next slide, please. Can you hear me?
Very clear,
Next slide,
Popa.
please.
Yes.
Yeah. So this on much more on direct actions and how do you make use of these flexibilities. The most important is the opposition system. I'm just giving a kind of a flavor about the pre-grant opposition. The civil society organizations alone have filed around 75 pre-grant oppositions. It might be slightly more, maybe nearly 100. We are compiling all those data. We will be able to give you much more accurate information in the coming days. My colleague is doing that. So far, the civil society organization has succeeded in 38 oppositions, and we failed, or our opposition got rejected in around 9 cases. Some of the success include bringing in many of the critical medicines, the generic versions like bedaquiline, dolutegravir, even earlier tenofovir. When it goes beyond even HIV or TB medicines, including some of the rare disease medicine, recently there was a opposition we filed. We succeeded in denying the patent application for a Trikafta patents. And sometimes what happens is that the patent may not even, opposition may not even go to the final stage. Before that, the patent applicant withdrew the patent application. So one example is that the medicine for TB, 3HP, where civil society organizations filed, I think, 2 patent opposition, and the applicant withdrew before reaching the hearing stage. So as a result, the medicine is used to be priced around $45, have come down to $15. So sometimes this may not reach to its logical conclusion, but we may have this desired result. Many third world network, MSF in the earlier days, as well as ITPC, all supporting these civil society organizations' initiatives on mainly supporting the patient groups to file these pre-grant oppositions. So now let me focus on other 2 initiatives by the civil society in India. Under the Indian law, it is very difficult for the civil society organizations to file for a compulsory license application, because the applicant has to prove the ability to produce that product. So that is for a civil society organization, it is impossible. So what is left is the government use, and the government use provision basically in the Indian Patent Act gives the discretion to the government to grant it or not. There is no way for a third party to apply it. It simply say that the government may issue a government use license. So now the civil societies organization working with the various affected parties, including patient groups or the patients, to argue in the court that any lack of access to the patent medicine does not provide that discretion to the government, but it is mandatory for the government to issue a compulsory license. And the last sentence, and then I am stopping it, the patient groups also, Third World Network and other civil society organizations encouraged many of the patient groups to intervene some of these patent enforcement litigations, like, which to argue that do not grant an injunction because access is an issue. Therefore, granting injunction is not a good idea. So we succeeded in the Risdi-Plam case, where this Roche has approached for an injunction, and the 2 patient groups, 2 patients or people living with SMA intervened in that with some of the technical support from us, and we could, in a way, convince the court to not to grant the injunction, citing public interest also. There was a other on ground for merit also was there, but court also noticed that there is a public interest. And let me stop.
Thank you, Popa. Highlighting part 2 and part 3 of the TRIPS agreement also. Very, very important to make that circle on the different types of TRIPS flexibilities that exist and the role of civil society. Last but not least of our respondents, and then we will open the floor to everybody, Sergej Kondratyuk, project manager of ITPC Global based in Ukraine. Sergej, the floor is yours.
Thank you, Yujit. Greetings from Kyiv, Ukraine. I will speak based on Make Medicines Affordable campaign experience, where we were supporting CSOs in filing oppositions in 24 countries over 10 years. Of course, it takes time for patent opposition to fruition and preparation, but impact on access is very significant. And I would provide some few good examples. I think here's my slides. Just a moment. So first example is bedaquiline case multi-country campaign, where bedaquiline is effective treatment for MDR-TB. Since 2013, at least 7 patent oppositions were filed in India by TB survivors and civil society organizations. And within MMA campaign, we supported 9 CSOs in 9 countries between 2020 and 2023 to file 18 patent oppositions against bedaquiline patent applications and patents. Combined this pressure with other CSOs advocacy, TB CSOs advocacy, it all resulted, as many of you know, in Johnson & Johnson seizing enforcement of bedaquiline patents in September 2023. And price dropped quite significantly, 78%.
Sergey, you have the same problem I have. We've been asked to speak slower. I have the same request when I speak.
Okay. Another case is Argentina with TDF FTC Faverens case, quite old one, but a good one, where price was more than $3,000 per treatment course. After 2 successful patent oppositions by Fundación GAP, the price dropped 22 times, and estimated cost of manufacturing, cost of savings for the government were around $50 million per year. Another successful 2 oppositions, more recent one by Fundación GAP, that came to good results on tenofovir alafenamide, led to securing local production and also generic competition and price reduction. Last examples of fosbuvir case in Ukraine were, as you know, it revolutionized hepatitis C treatment in general. So Gilead provided a access price $1,350 after patent opposition succeeded in 2017 July by full rejection of the patent. In August, Gilead added to voluntary license Ukraine, Thailand, Malaysia, Belarus, and most importantly, Malaysia was also at the time moving to finalization of their compulsory license. And as a result, in Ukraine, the generic competition led to $60 price for a full treatment course, which is roughly 22 times lower price than the access price from Gilead. And the Ministry of Health was able to redistribute just in first year $2 million for additional treatment courses for hepatitis C program. So as CSO-led patent oppositions work, I would call and believe that we need to scale them up. Important components to this are capacity building, because it's important in terms of sustainability, as civil society groups will be always on the ground and they will be always continue the work, no matter how hard it is or whether there are some interruptions in donor funding, etc. Communication is very important because it can change narrative and can be used then to improve patent opposition cases could be used to improve patent examinations. We did it in Ukraine, for example, on lopinavir-ritonavir case, which was really good in terms of showing it was most expensive drug for Ministry of Health budget. And AbbVie used heat stable dosage form, very like secondary evergreen patent, which was easy to kind of to show to patent office, and it improved our dialogue with them on law reform. And of course, last but not least is legal environment. You need a procedure for patent opposition, like ideally third-party observations, pre-grant, post-grant oppositions at administrative level, without too high fees and too limiting periods for filing oppositions. And of course, the patentability criteria will define how successful opposition will be in many cases, because if country has not excluded method of treatment or prohibited also second medical uses, then companies will go through this route, will get lots of patents, and it will be hard to oppose them in such country as compared to country which excluded methods of treatment and prohibited second medical use from subject matter. So to conclude, yeah, we need to scale up civil society work on patent oppositions and support as much as possible and build capacity on the ground. Thank you.
Thank you, Sergio. Just on time. Perfect. So now we're going to open the floor for questions, comments, suggestions on how to strengthen this work, as well as any concerns, any advice. I see on the chat already a question for Jamie. Jamie, I don't know if you see it. If not, we can read for you. But I appreciate if anybody who wants to make a point, you can write it in the chat or you can raise your hand and we will be calling you. We have over 43 participants joining us right now. So please do not be shy. No sean tímidos. Levanten la mano si quieren complementar alguna de las presentaciones o hacer alguna sugerencia adicional en el chat o levantando la mano. Muy bien. Veo a Luis Villarroel. Jamie, do you want to address the question on the that's been raised for you on the chat? You want some time? Luis, the floor is yours.
Well, yeah, for the question, if you could repeat it for me.
Okay. Luis, the floor is yours. We will look for the question, Jamie.
Okay. No. Well, thank you for this event. Very interesting. I think that to make things work better, we need to share more information of what all civil society is doing and where. So probably if we could create a map, geographical map where people will include, the organization and the push that is doing, maybe that could help to have more synergies, because I see that there's a lot of things going on and we don't know much about it.
Thank you. I see Jamie, Health Action International, has put the question on the chat. If you want to read it and think about the answer, I see Brooke Baker raising his hand now.
Well, if I put I don't know if it went in the chat there. Yeah, I put a link to like several hundred of the the FAR cases that I mentioned before, where the U.S. government puts a clause in a contract, and you can see who the beneficiaries of a wide range of companies. And by the way, we really so they're not all about health. Most of them are about health on this list, but they're not all about health. And you have big companies like big pharma companies. You have small companies. You have companies you've never heard of before. The medical device companies are often the beneficiaries of the injunction cases, are the leading companies that manufacture diagnostic tests and medical devices, and they get sued by some patent owner, and then they try and avoid. But it goes both ways. Sometimes the generic companies are the beneficiaries. So it's lots of different companies benefit from these limitations on injunctions. There's a recent case, I put a link in there, in Europe, at the European Patent Court, which is really important, where they ruled that the public interest of the patients that are affected by the lack of access to a medical device, it was a heart valve case, can be given the justification to withhold. So there was one nuanced case where an Indian manufacturer of a generic medical device was allowed to sell it in Europe, despite the fact that there was a patent there, and the patent was valid because of the interest of patients who would benefit from the device.
Thank you, Jimmy. Brooke, the floor is yours.
So this is a great webinar on use of the TRIPS flexibilities, but we have not heard much discussion on enacting them or the law reform needed. And, it seems that as a movement, we've been less successful in initiating reform activities. I know that, a reform effort was launched in South Africa in 2011. An actual bill has been sitting on the desk of the Department of Commerce and Trade for over 6 years, but may finally be seeing the light of day in the next few months. But one question to our panelists is, can we re-energize or shouldn't we re-energize the campaign for law reform? Some colleagues and I from a BU program have written an analysis of patent legislation and TRIPS flexibility legislation in particular in several middle-income countries typically left out of voluntary licenses, and the work that could be done in those settings to increase the definition of TRIPS flexibilities and their ease of use. And then the second thing we haven't talked about much is the growing threat of free trade agreements. All of us have worked to oppose the TRIPS Plus agenda, but it's being enacted, in a very ruthless way right now without even the time period and minimal transparency that we've had in the past. That's given us time to mobilize and make arguments and have some impacts. The U.S. America First memorandum of understanding being used as leverage to extract just, open-ended commitments to essentially end all use of TRIPS flexibilities and to follow pharma's prescriptions and special 301 reports is really problematic. So I hope we can supplement this excellent discussion today with future discussions on both enacting and protecting TRIPS flexibilities.
Thank you. We're going to be moving to final remarks and final thoughts, but I see, Sergio, you have a question also on the chat. Do you see it?
Oh, sorry.
No, it's okay. It's a very technical question about patent search results. I think what I will encourage, if you feel comfortable, all the speakers to share your contact information on the chat, as well as to provide materials and additional information so the audience can continue learning about your work, because I know we just gave an appetizer, as we say in Spanish, a little tapita of your work, and every one of your presentations deserve an hour and a half. So maybe if you're comfortable, put your contact information, put the information of the slides, the slides that you have provided, your website, so the dialogue can continue after this webinar. I'm conscious of the time, so I'm going to invite Jaume, final remarks, or should we give 1 minute to all the speakers? Is your webinar, is your call? What do you prefer?
If any of the speakers have like one final minute, go ahead, and if not, I will close.
Final remarks, you and me. Okay, so as speakers, do you have 1 minute final thought, final advice, in positive, what has worked, what needs to happen next, or in negative, what has not worked? We are among friends, 54 friends right now. Jamie and Luis and Juliana, I see 3 hands.
Yeah, I mean, I'm trying to lower my hands here. I think that Burke's point is really, and I think other people have mentioned this too. Sergi, and other people mentioned. I think that the law reform is really important. I think that one thing you can look at for a lot of the cases that have not succeeded is because the national law is either too complicated, the process takes too long, it has bad conditions. There's just not enough attention and not enough pressure on countries to adopt best practices. And the best practices would be on things like, how long can negotiations take place? Like, for some places, it's like, what do you do in remuneration? I think certainly the import-export issue is super important. And there's a couple of really good examples how you can address that. But most of the laws are really crap on this. Thank you.
Thank you. I see Juliana, then Luis, and then Sergio, and then we will finalize.
Thank you so much. I'm going to speak in Spanish, sorry. Bueno, yo solo quiero dejar como una reflexión de fondo y es también empezarnos a pensar criterios estrictos de patentabilidad en nuestros países, ya que eso puede permitir conceder patentes solo a aquellos productos que realmente cumplan con criterios necesarios para gozar de este privilegio. Creo que con con la implementación de criterios estrictos de patentabilidad, podemos realmente evitar la concesión de patentes que no, pues, inmerecidas. Y ahí hago también como un llamamiento a todos a que defendamos el manual de patentes argentino que recientemente derogó el gobierno de Milei. Entonces, solo quisiera dejar eso como para la reflexión. Gracias.
Gracias, Juliana. Luis and Sergey.
Well, thank you. Just to respond, Brooke, there are a number of law reforms that are on the way, just that we didn't have time to discuss. So it's good that we could discuss it later. But my message is, I think we need to change the narrative when we approach to the law reforms, because we have seen that just to mention humanitarian reasons, it really doesn't buy as well if you presented that this flexibilities are important for development in general. So I will encourage to work on that. Also, I think that there is a field of policy that is extremely influential, that is related to investment bank, that the finance the countries. If we are able to get this need of flexibilities for development in those places, then they will be easier to go to national laws.
Gracias, Sergey. And then we're going to close.
Just to say that for law reform, it is very important not to have too many TRIPS Plus obligations. So latest wave of FTAs signed with quite negative results in various countries is something that we need to work a lot all together, because it will block any future law reform work. And there is also smaller wave. For example, Costa Rica law was signed in 2024. EPO validation agreement, so we are losing on the field of patentability criteria. Countries are losing their sovereignty in this way, and they will not be able to shape their industrial policy by applying strictly and ensuring freedom for their local manufacturers. So we need to keep an eye on it and work on it. Thank you.
Policy space. Yep. Jaume Vidal. Hi.
Thank you. Thank you. Well, I want to close this webinar a little bit highlighting some of the aspects that we have been addressing, and I think that this last round by all the speakers, I think it's really important because it's really at the core of the work that we need to do from now on. I think that we need better coordination among ourselves. We need better collaboration with other actors outside our silo. And Sergey said something here that I hadn't thought about it, but when a government changes the patentability rules, is giving up sovereignty, is renouncing to policy space for industrial policy, for health goals. And I think it's important that we frame the narrative, as Luis was saying, also looking at this. There's still too many people that look at these flexibilities as last resort measure. It's a way of really casting doubt about the legitimacy of these tools. I think that we need to insist. We need to keep on working. I think that we have seen a lot of examples of civil society really pushing the agenda, really making the change happen. And I think that we need to insist. And I would like to really, before we go, to give thanks to our interpreter. I think that he has done a terrific work with people like me and others talking super fast, slides being stuck and improvising. I think it's really good. And also I want to acknowledge that we had this interpreter thanks to Public Citizen that make it possible. And I would like to thank all the speakers and especially our moderator that was really good. I mean, she pulled it off. I mean, it's really amazing. And in a way that it was not too aggressive, it was not too harsh. So it's nice. And also thank you to all participants. We will be sending the recording of this webinar with the presentations and the bios of all participants. Thank you.
Thank you all. Thank you, Jaume. This work matters. We need to scale up. We need to continue. We need to ensure that civil society funding is secure for this kind of work. Thank you, everybody. La lucha continúa.